Honorable Chairperson, panelists, and learned audience, a very good morning. I'm Dr. Lima Asrin Sayami, working as Assistant Professor in NICVD. So challenges are the parts and parcel of intervention. In intervention, you never know what is waiting for you until you go in. So courage to deal with the challenges, planning, perfect planning, and then prompt response is required for success in intervention. My case is a 54-year-old male who presented with chronic stable angina on the background of hypertension and diabetes. In ECG, there was ST segment depression in the inferior leads, and echo showed inferior wall hypokinesia with an ejection fraction of 46%. So patient had done coronary angiogram in another hospital, and coronary angiogram revealed normal left system, and there was CTO in RCA. So patient was admitted in our hospital for PCI in CTO RCA. So we planned for doing PCI in radial route, but there was difficulty in engagement because of the tortuous course of subclavian artery. You can see how tortuous it is, and with difficulty we could engage the RCA. So RCA was a ugly looking vessel, so disease from proximal part and a CTO from the mid part. With the aid of microcatheter fine cross, we could cross the CTO with pilot 150 and pre-dilated the vessel with 210 balloon. After pre-dilatation, we took picture. We can see frank leakage of blood from the mid part, so there is a perforation. After prolonged inflation with balloon for about 10 minutes, the perforation sealed, and we stented the vessel with 332 millimeter stent. Then we took picture whether the perforation is perfectly sealed or not. Then we see that in the proximal end of the stent, there is a long dissection. So we need another stent overlapping with the previous stent to seal the dissection, but we missed the entry point of the dissection. It required another stent to seal the entry point, about 3.5 to 12 millimeter stent, and we can see that dissection and perforation perfectly sealed, but there was significant stenosis in the osteoproximal part of PDA, so we need another stent to 2.5, 12 millimeter stent to stent that part, and this is the final picture. So if you consider the mechanism and site of perforation, perforation can be large vessel perforation, distal wall perforation, and collateral septal or epicardial perforation. Whatever may be the cause or site of perforation, we should follow the universal algorithm, that is prolonged balloon inflation, intravenous fluid or vasopressor. Pericardiocentesis is hypotension or autotransfusion if needed, and we should notify the surgeon. If there is no persistent extravasation, we can monitor the patient. If there is persistent extravasation, we can treat the cause. That is, if there is last perforation, even after prolonged balloon inflation, the perforation exists, then we can use cover stent, or you can use dissection techniques. In case of distal vessel perforation, we can embolize with fatter coils or use covered stent over the perforated branch. If continued extravasation, we should reverse the anticoagulant and send the patient for surgery. For iatrogenic coronary artery dissection, most difficult part is wiring the dissected segment. I will not go into details because my previous presenter already discussed it. So learning point in my case is there was a lot of obstacle. There's difficulty in engagement, then crossing the CTO, then perforation occur and dissection occurs. So we have to keep our head cool and carry on. We should follow this 4S law. These 4S are stable, smart, swift, and stent. Stable. The operator should be emotionally stable, and the guide wire and guide catheter should be stable, and patient should be hemodynamically stable, and the operator should be smart and cool-headed, and take proper decisions. And the operator should be swift to call other medical staff and prepare temporary cardiac pacing, electrical cardioversion, tracheal intubation, and cardiopulmonary resuscitation if required. And ultimately, stenting, the immediate bailout stenting will save the patient in most cases. Thank you all for patience hearing.